today is cesarean birth. We all know it as CS, cesarean section. Now, what do we mean by cesarean section? It's a pattern of delivery, a method of delivery, aided, where there's a cut given at your abdomen, your lower abdomen, or at the middle of by your umbilical, depending on how your gynecologist sees fit for your body. It differs in size. If you're a slim person, we use the abdomen. I'll tell you why. And if you're a chubby person, we use here. So now, why it's like that is because slim people, we don't have a lot of fats in our body, right? And even though you have a cut here, you know that here, if you're wearing pants, you're wearing tights. On a normal day as a girl, you're wearing tights, you're wearing pants, everything. There is no air entering here. And as a slim person, there is no overlapping fats, no nothing. Everywhere is okay. So you can have your cut here. But as a fat person with folds and all that, you can't have your cut here because the heat will be too much. And you might have a womb breakdown. So that's why you notice most of the chubby people have their CS cut here. Except your gynecologist has seen that, okay, probably your skin is different. Before they put a knife on you, they are assessing your body. We do physical examination aside your normal regular ANT visit to come for. So we have reasons for cesarean section. We can't just see you in the hospital and say we want to open you up. No, there are reasons for cesarean section, and there are a lot of reasons for cesarean section. Now, the first reason is yourself, your choice is elective. So mothers don't want to go through pain. And forget this thing that people tell you, hey, I want to go through the pain, let me know I'm a mother. Nobody should deceive you. Whether you give birth to CS, whether you give birth vaginally, you're a mother. Because CS pain is not a man that's going through CS pain, it's not a woman. CS pain might be even unbearable than normal delivery. Because normal delivery, let me just say in less than a week, you're beginning to get yourself, you can go to the market on your own and all that. But CS, you still be dependent. So it's not like, but it's not a bad thing. That's what I'm saying. But people say, some people say, my mother gave birth to us, 6 of us. My mother gave birth to 7 of us, and she's not this year. It is not my portion. Don't be saying that kind of thing. When you're pregnant, it's 50-50. Because your life and your baby's life is in one. Anything that is affecting you is affecting your baby. So if a medical doctor tells you, or your personal physician tells you, oh, see, I think with these reasons, you cannot push. Please don't fight. Please don't carry church and say, Pastor, this will heal me. I'm going to camp to go and give birth. Don't do that to your baby. Now, I'm not saying it's you. Don't do that to your baby. The baby is innocent. That doesn't know anything. And you as an adult, you're supposed to know that, okay, before they'll tell me to do this thing, it's actually very important. Do you understand? Now, we have your health, the maternal health. Now, a woman that has hypertensive crisis all the time, and probably you have pregnancy-induced hypertension. Most times, you've never experienced BP rise before in your life. But since you got pregnant, your BP is always at a spike. And that's now, you're going to manage it till when you've gotten to term. You're following up with your gynecologist, you're following up with your midwife. That's when they're going to tell you, oh, because of this, you can't push. Now, let me tell you what goes on with your BP when you're in labor. You know it's pain. Pain makes you lose control. You don't want to eat anything. Small menstrual cramps that is doing me, I'll be crying. You know how menses can be painful. You lose appetite. Somebody's touching you, irritates. I say, don't touch me. Now this is labor pain. Menses is just like 1 cm or 2 cm dilation. In labor, you have to reach 10. So it's like you're having triple or double of the pain you're having in cramps. So imagine how your BP is going to be going up. With that, you can't push. You can't allow you to push. It's not safe. It's not a bad thing. It is not a bad thing. It's not that when I have my baby, the first child I have, no problem. The second child, no problem. Every pregnancy is different. Every pregnancy, the way A did for you, B will not do like that. If B was not difficult, A might be difficult. Do we understand ourselves? Yes. So we have the positioning of your baby. Now, if your baby is not positioned well, I know that when pregnancy is progressing at the early stage, your baby can lie anyhow. But when it's getting to when you're supposed to be due, it's expected that normally your baby should assume the position that's, how will I say it, I understand. Your baby's head is facing down. Do you understand? Not the buttocks, not any, just the head down. But now we have seen that, okay, you're 37 weeks, you're 38 weeks, and your baby did not turn. Your baby is either in breech or transverse. Breech is the buttocks that is coming out. Transverse is lying like this. The head might be this side, leg might be this side. That means it's the middle that is here. Or it's like this. Somehow slanted, but it's not straight. That's transverse. So when you see that kind of complication and tell you, this is it, this is what your scan. That's why it's important to do scan during your period of pregnancy. So in that stage, you don't have to struggle and say, I'm not doing CS, I'm not doing this one. In that part, you don't have a choice because you have to save your baby and save yourself. So are you telling me that you're not going to do that? Nobody's praying for that. But to be on the safe side, you have to adhere to CS recommendations from your gynecologist, especially somebody that's been taking care of you from the onset of your pregnancy. That's why you should learn how to trust your gynecologist or your midwife or your nurses that are in charge of your health, your pregnancy, and your baby. Nobody wants to do any harm to you and your baby, right? So we have another thing called placenta previa. Placenta previa. Now your placenta is not beside your uterine wall, sticking to it, but it's now covering your cervix. Once your placenta is covering your cervix, if you've given birth before, you know that when you're contracting, we do vaginal examination. Now we know that vaginal examination is painful, it's not comfortable, but it's not like we like it, but we have to do it to know where you are. Now imagine we are checking your dilatation, and I put my finger, removing it out. I look at my fingers, what I am seeing in my finger that I am working with. I'm seeing product of conception is placenta. I will know that I don't need anybody to tell me that your placenta is out first, and it's very risky. And when it happens like that, you go in for CS because you can't deliver your placenta first before your baby. So we have previous CS, previous history of CS. It's not that when you've had CS for your first baby, you can't deliver vaginally. That's what I'm saying. Now, if you've had CS 1 time, 2 times, it depends on the time you give yourself, the duration you give your body to heal, and the scar. You know, they're cutting through your abdomen, they're cutting through your uterus to bring out your baby. Now, when they're stitching your uterus together, it's not the way God created it anymore. There is a scar. So if your baby is just 1 year and you're taking in again, you don't expect us to let you go through vaginal delivery. Because now, you know how contraction is. Everything in your abdomen is squeezing, is stretching, and that is a scar that has not healed properly. What do you think will happen? It's a tear. But if you give yourself time, 2 years, some people leave themselves 3 years, and you're coming, and we have checked you and know that, okay, you don't have any issues and everything, we let you go through it, and you deliver. So CS is not bad. It's just for you to understand how CS works and when you need it. Some people might not need it, but the pain, you say, I can't do it again, I can't do it again. It's now her choice for you to stop the labor and do CS.
Prolonged labor, also known as failure to progress. This means labor has started but is not moving forward as expected. The cervix may stop opening, or the baby may not descend into the birth canal despite strong contractions. At this point, continuing labor can exhaust the mother and put the baby at risk of infection or distress. A caesarean section is then recommended to safely deliver the baby rather than allowing labor to continue dangerously. Fetal distress. This refers to signs that the baby is not getting enough oxygen inside the womb. We detect this mainly through an abnormal heartbeat pattern during monitoring. If this happens and cannot be corrected quickly, for example by changing the mother's position or giving oxygen, the safest option is an urgent C-section to prevent brain injury or complications for the baby. Umbilical cord problems, cord prolapse. This happens when the umbilical cord slips down into the vagina before the baby. The baby's head can press on the cord and stop oxygen supply. This is an emergency because the baby depends completely on that cord for oxygen. Immediate caesarean delivery is required. Placental abruption. Here, the placenta separates from the womb before the baby is born. The placenta is the baby's life support. Once it detaches, the baby loses oxygen and the mother can bleed heavily. A quick caesarean delivery is usually necessary to save both mother and baby. Maternal health concerns, e.g., severe preeclampsia. Conditions such as very high blood pressure, seizures risk, or serious illness in the mother can make vaginal delivery dangerous or too slow. In these cases, delivering the baby surgically protects the life of the mother and prevents complications. The procedure, what to expect 1. Preparation. Before the surgery. A drip, 4-line, is placed to give fluids and medications. A catheter is inserted so the bladder stays empty during surgery. The abdomen is cleaned with antiseptic to prevent infection. A sterile screen is placed so the mother does not see the surgical area. You will remain awake and your partner may be allowed beside you depending on hospital policy. 2. Anesthesia. Most mothers receive spinal or epidural anesthesia. This numbs you from the chest downward so you feel pressure and movement but no pain. General anesthesia, sleeping completely, is only used in emergencies or special medical conditions. 3. The incision. Skin incision, usually a horizontal, bikini line, cut just above the pubic hairline. It heals better and looks neater. Uterine incision, also typically horizontal. This type is stronger and allows many women the chance of vaginal birth in future pregnancies. 4. Delivery of the baby. The doctor opens the womb, breaks the water, and gently lifts the baby out. This part is usually quick, often within 5 to 10 minutes after surgery begins. You may feel pressure or pulling but not pain. The baby is shown to you, cleaned, and the cord is cut. 5. After delivery. The placenta is removed. The womb and skin are stitched. Stitches usually dissolve, sometimes staples are removed after a few days. The whole operation takes about 45 minutes to 1 hour. Recovery after a C-section. Recovery is slower than vaginal birth because it is major abdominal surgery. Hospital stay, about 2 to 4 days. Pain management. You will feel incision pain and uterine cramps, after pains. Pain medication is given and is safe for breastfeeding. Movement. We encourage early gentle walking within 24 hours. This prevents blood clots, helps bowel movement, speeds healing. Avoid heavy activity for 6 to 8 weeks. At-home care. Keep wound clean and dry. Do not lift heavier than your baby. Watch for danger signs. Fever, redness or swelling, pause discharge, bad smell, increasing pain, postpartum bleeding. You will still have vaginal bleeding, lochia, just like vaginal birth. Risks and considerations for the mother. Because it is surgery, risks include wound infection, increased bleeding, blood clots, injury to nearby organs, rare, reaction to anesthesia, longer recovery, slightly higher risk in future pregnancies. For the baby, fast breathing after birth, temporary lung fluid, small accidental skin cut, rare, possible NICU care if premature. Future pregnancies. Many women can still have normal deliveries later. VBIC, vaginal birth after Caesarean, is possible for many mothers depending on reason for first C-section, type of uterine scar, current pregnancy condition. However, risks like placenta previa or placenta accreta slightly increase with multiple C-sections. Key takeaway, teaching emphasis. A Caesarean section is not a failure and not something to fear. It is a medical procedure used to protect the life of the mother and baby when vaginal birth is unsafe. The goal is always healthy mother plus healthy baby. Always discuss your birth plan, fears, and preferences with your doctor or midwife so the safest decision can be made for you. At ROA Specialist Hospital, the safety of both mother and baby is our top priority. Join our antenatal classes for more guidance and updates.